BC Centre for Substance Use, or BCCSU for short, is a provincially networked resource with a mandate to develop, implement, and evaluate evidence-based approaches to substance use and addiction. While a lot of the important research that they do is quantitative, in other words, they crunch numbers and statistics to support or refute hypotheses and make conclusions, there's a growing body of qualitative research, which includes listening to what a particular population of interest has to say and looking for themes and ideas on how to improve their experience. This research can often inform improvements in programs or policies, or even just elucidate deficiencies in a system that we didn't even know existed. The Youth Health Team is one of the groups at the BCCSU who's performing research like this. It includes academics, clinicians, and medical undergraduate students, like me. But the most essential part of the Youth Health Team is the Youth Health Advisory Council. The Youth Health Advisory Council, we call it the YHAC for short, is composed of youth with real-life experience with substance use in the context of homelessness or unstable housing. This street entrenchment frequently occurs in the context of other kinds of overlapping exclusion along axes of race, class, sexuality, gender, and ability. In other words, life's often tough for a multitude of reasons. Since one of the ultimate goals of the Youth Health Team is to bring about change for young people who use drugs, it's important that incoming researchers are orientated appropriately. For this purpose, the YHAC has been hosting a field school for incoming members of the Youth Health Team since 2020. As a medical student, I learned so much from working with the YHAC that I set out to create 10 simple lessons that are intended to help physicians, nurse practitioners, and other clinicians effectively engage with this population. Here's what I learned by attending the YHAC field school. Lesson number 0, acknowledge your privilege. Now, hear me out here. I'm not trying to be moralistic or tell you that you didn't work hard to get to where you are in life, but as care providers, I want us all to just take a moment to acknowledge that we have significant privilege in society, and this needs to be at the forefront of our mind when we are working with youth who experience street entrenchment. From personal experience, I know that when you don't have enough money to know where your next meal is coming from, even seeing someone who's wearing a formal dress shirt and tie or a white coat can make them seem like they're from another planet. Now imagine that this individual has the power to determine whether or not you gain access to the care that you need. It can be pretty uncomfortable. Acknowledging this difference in power between physicians and young patients is important for understanding the distrust that young people often have towards medical professionals. If we're able to understand this power differential, it allows us to see where we might be able to use our privilege to advocate for youth. Lesson number 1, care for youth should be voluntary. One of the most exciting and pivotal things about working with the Youth Health Advisory Council is that they get the final review of any pieces that the Youth Health Team produces. They wanted me to emphasize, before going over ways in which to go about care or treatment, that care in their eyes should always be voluntary. It should go without saying that in order to have an effective therapeutic relationship with an individual, especially in a patient-centered way, the therapeutic alliance should be established in the sense that the patient has both consented to and expressed interest in treatment. So before we get all excited about jumping to solutions, let's all take a mental note that we should first establish that the person in front of us wants the services that are being offered and feels empowered to consent or deny what we're offering. So with that being said, let's move on to lesson number 2. Don't just push medications in the absence of other kinds of support. Many young people, perhaps especially those who grew up in government care, feel strongly that they've been over-medicated their entire lives, oftentimes without their consent or active participation in developing treatment plans, timelines, all the kind of things that you would hope to experience when starting a new medication. A focus on medications in the absence of other kinds of support, like housing, income, counseling, advocacy, reinforces this sense of distrust towards providers. Lesson number 3, involve youth as partners in treatment planning. Youth often don't feel listened to when it comes to making decisions about treatment. This is especially true with regards to medication-assisted therapies such as opioid agonist therapies and psychotropic medications, for example, stimulants or mood stabilizers. The result is that youth feel unheard and like they have little to no control over their healthcare trajectories. Again, further fueling this distrust of providers and leading some to disengage from care. Physicians and nurse practitioners could consider collaborating with youth to develop treatment plans and timelines that can be quickly adapted to youth circumstances, needs, and and desires as they change. This may include providing a clear and explicit pathway to tapering opioid agonist therapy when a youth expresses a desire for this option. In other words, they might want to know when their taper is going to start, how it's going to look, when it's going to end. Otherwise, they often decide to take matters into their own hands and self-taper to meet their own expectations. Lesson number 4. Many youth don't want to feel like you're pushing buprenorphine naloxone over other forms of opioid agonist therapy. Now, many care providers and clinical researchers know the age-old tale about the difference between efficacy, or what works in the clinical trials, versus effectiveness, or what works in practice outside of the confines of a clinical trial with controlled variables and exclusion criteria. These clinical trials largely inform our treatment guidelines around opioid agonist therapy and youth, and as such, they can contradict youth's lived experience with which form of opioid agonist therapy is the best fit for them. Patients don't read the clinical trials, they don't follow the textbooks, they have their own life and set of circumstances. Youth who indicate that they want treatment should have access to the full range of opioid agonist therapy, including methadone, including slow-release oral morphine, and buprenorphine naloxone. Another thing to consider is that risk mitigation prescriptions of substances such as hydromorphone can also be beneficial for some youth, particularly those who are transitioning to opioid agonist therapy. Lesson number 5. Daily witness dosing and limited take-home dosing of opioid agonist therapy can reduce treatment retention for some young people who use drugs. Young people who use drugs who have missed consecutive doses of opioid agonist therapy are required to restart their medication on the lowest recommended dose. Particularly in the context of the everyday emergencies of poverty, homelessness, and unstable housing, the hassle of restarting opioid agonist therapy, as well as daily witness dosing requirements, can discourage retention and lead to treatment disengagement and eventual relapse. For these young people who have missed previous doses, a patient-centered approach to restarting opioid agonist therapy is needed. It should aim to get them back to a dose that works for them as quickly as possible. Otherwise, there may be increased risk of inadequate treatment, withdrawal, and relapse. Flexible take-home dosing of buprenorphine naloxone is endorsed by the BCCSU guidelines, and recent evidence suggests that take-home doses of methadone maintenance therapy during the pandemic have been safe and practical. Physicians might then more readily consider take-home dosing of opioid agonist therapy for youth, if the situation makes sense. Physicians could also consider offering to switch youth to a form of opioid agonist therapy that has more leeway in terms of the number of missed doses before having to restart. Other straightforward things providers can do to help youth who use drugs include helping them gain access to opioid agonist deliveries or finding pharmacies with more flexible hours for witness dosing. Lesson number 6. Create treatment programs, services, and systems that help youth get somewhere. Youth often describe ambivalence towards treatment programs, services, and systems because they do not get them closer to the lives that they want for themselves. Medication just isn't enough. Youth need housing, employment, and income supports, as well as supports to help them build healthy relationships with their family, friends, romantic partners, and service providers. Lesson number 7. Adopt a harm reduction first approach when working with youth. It is true that some youth may want to pursue abstinence from drugs as quickly as possible. Others, however, feel like drugs play a vital role in their lives and mental and physical health. I think that sometimes it can be really hard for healthcare providers or society in general to even imagine that drugs may be perceived as playing a useful or functional role in an individual's life. Consider listening to young people about how drugs are both negatively and positively impacting their lives, be it socially, physically, mentally, or emotionally. Physicians' attempts to quote-unquote fix young people's substance use can have the effect of pushing some individuals further away from life-saving care. Consider connecting young people with youth-dedicated drop-in centers that prioritize harm reduction and relationship, trust, and future building. Also explore what they're already doing to reduce harm for themselves. They've managed up until this point in some way or another. Lesson number 8. Don't treat youth like they can be reduced to their charts, records, and files. When youth are approached purely based on what's written in their charts, files, and records, it can often make them feel like these documents are being used to put them in boxes and penalize them. Sometimes it can feel like they don't even have a chance to a fresh start. Providers should get to know the young person in front of them. focus on where they're at in the present. Connecting young people with the same physician across time and fostering continuity of care is one way to help with this. Lesson number 9. If it hasn't already been emphasized before, advocate for youth. Some of the most positive experiences the YHAC members had with physicians were when they took the time to advocate for them and try to address factors such as housing, school, income, and relationship issues. Lesson number 10. Build rapport and relationships with youth, no matter what your background. While many youth appreciate it when those providing care have lived and living experience with some of the issues that they've faced, this is not necessary to build rapport and relationships with them. Compassion, acceptance, interest, and empathy can all go a long way. Actively listen to youth and get to know them and where they're coming from.
The cards won't show those who don't toast me. I shoulder the scars, watch me become ghostly when I flow through the hardship and achieve my dreams totally.